ये क्यों आ रहा है?
हाँ भी आ गया।
So we are live now.
Yeah, you can start.
So good evening to all respected delegates and faculty members who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 173rd edition of Happy Learning Masterclass webinar series in association with Azamgarh, Gorakhpur, Jaunpur, Mau, Mirzapur and Varanasi. The theme for today's webinar is Mixed Bag. And the convener for today's webinar is Dr. Asha Jain. Let me introduce Dr. Asha Jain, ma'am. Madam has 32 years of experience in
Nilesh, make it really short. Most of them know me. Just make it couple of lines.
Okay, madam. Madam has 32 years of experience and madam has Foxy Register Ultrasound and Colposcopic Training Center. Currently, madam is Director SMSA Raipur Hospital Raipur. And madam's fields of interest are saving uterus, fetal medicine, obs and gyn ultrasound, critical care, and preventive oncology and colposcopy. So I welcome Dr. Asha Jain, madam.
Thank you.
Our coordinator for today's webinar is Dr. Rekha Rajendra Kumar, ma'am. Madam is practicing gynecologist for the past 31 years. Madam is President-elect BSOG from 2023 to 2024. And Madam is also invited faculty in more than 700 state, national and international conferences. Madam has also received various awards and felicitations. And Madam has also done more than 100 radio and television talks, 40 newspaper articles on women's health. So I welcome Dr. Rekha Rajendra Kumar as well. And as per the traditional course, we are going to start our webinar with a lamp lighting session. Thank you so much, all respected doctors. Now I will hand over the session to Dr. Asha Jain. So over to you, madam.
Thank you so much, Nilesh. Namaskar. I welcome all the respected faculty to this program. And for the official welcome address, I invite the director of this program, Dr. MC Patel, sir. He is somebody we all know. And this program, taking it to 173, is his brainchild. So over to you, sir, for the official welcome address.
Thank you. Thank you, Dr. Asha. It gives me immense pleasure to welcome you all on this 173rd episode of Happy Learning Masterclass web series. And joining society, Azamgarh, Gorakhpur, Jaunpur, Mau, Mirzapur, and Varanasi. So I welcome Dr. Anuradha Khanna madam from Varanasi, Dr. Radha Jina madam from Gorakhpur, and Dr. Vibha Misra madam from Varanasi. They all have kindly consented to be guest of honor to bless the webinar. I am lucky that all of them are always with me any of my academic activity. So welcome Anuradha madam, Radha madam, and Vibha madam. I also welcome Dr. Reena Srivastava madam. She is going to discuss very important topic in our day-to-day obstetric practice, CTG, interpretation for optimum perinatal outcome. So welcome Reena madam. And to chair that very important session, I welcome three learned chairperson, Dr. Sadhana Gupta from Gorakhpur, Dr. Nisha Rani Madam from Varanasi, and Dr. Surita Karim Madam from Gorakhpur. I also welcome all the learned panelists who are going to bombard question to me, because today it is reverse panel. Panelists will be asking and I will be answering. So I welcome Dr. Seema Pandey from Azamgarh, Dr. Archana Messi from Azamgarh, Dr. Savita Agarwal Madam from Gorakhpur, Dr. Alpana Agarwal Madam from Gorakhpur, Dr. Ambar Khan Madam from Jaunpur, Dr. Kusum Verma Madam from Mau, Dr. Akika Singh Madam from Mau, Dr. Meena Jain Madam from Mirzapur, Dr. Meena Vishwakarma Madam from Mirzapur, Dr. Sikha Sachan from Varanasi, Dr. Amrita Jaipuria from Gorakhpur, Dr. Uma Pandey from Varanasi, Dr. Archana Misra Madam from Varanasi, Dr. Babita Shukla from Gorakhpur, Dr. Upma Yadav Jaiswal Madam from Gorakhpur, and Dr. Bharti Rajsekhar from Hassan. I also welcome two conveners, Dr. Ritu Khanna. I would like to put it on record all the help and support she has extended, not only for this webinar, but whenever I have called Ritu, Ritu is always with me in any of my academic activity. So my special thanks to Dr. Ritu, and welcome Ritu as a convener. I also welcome Dr. Asha Jain. She is one more convener, not only with this series, but she is since long in this series. So welcome Dr. Asha Jain. I also welcome Dr. Rekha Rajendra Kumar. She is coordinator for this series since long. She is president-elect from Bengaluru Society. And all the president and secretary of joining society and all the delegates who have joined this webinar. So in era of COVID-19, where physical meetings were not possible, we four friends started this series. And now I am happy to announce now it is more than 7,000 plus member of Happy Learning Masterclass web series. We usually discuss focus topic and discuss one medical legal topic also. And this is our fourth round with all the societies of FOXY. We have already completed 3 rounds. And with this fourth round, we have started reverse panel as far as medical legal issues are concerned. So with this background, welcoming you all without wasting much of your time between academics. I welcome you all. Thank you. Thank you very much.
Thank you, sir. Now I would like to invite Dr. Ritu Khanna, ma'am, who has coordinated this program. Ma'am, say a few words, please.
Thank you so much, Dr. Asha, and my heartiest congratulations. And we are so happy, sir, MC Patel, sir, that it's the 173rd edition, such a persistent, and I think we love the series, the Happy Learning series. And we are so much benefited with each and every topic that is picked up, and the interaction that we have. And thank you for bringing us all together on this platform. And my respectful regards to our guest of honors, Dr. Anuradha Khanna Madam, Dr. Radha Jinna, Dr. Vibha Mishra Madam, and also Dr. Reena Srivastava Madam, who spontaneously she never says a no to anything unless she's stuck up. Thank you so much, Madam. You always give us your precious time. And all the chairpersons, Dr. Sadhana Gupta Madam, Dr. Nisha Rani ma'am, and Dr. Surita Karim, who are also there with us, and we are so happy to have you all. And my thanks to President Secretaries of Azamgarh Society, Gorakhpur, Jaunpur, Mau, Mirzapur, and Varanasi, who just joined us at one go. And I'm lucky to have convener and coordinators as Dr. Asha and Dr. Rekha Rajendra, so dedicated into their work. So thank you so much, and wish we have a very, very great, successful academic event. Thank you so much.
Thank you. Thank you, Ritu.
Nilesh, may I have the CV of Anuradha, ma'am, please? So I would like to welcome and invite Professor Anuradha Khanna, ma'am, for her blessings to this webinar. She is ex-head Department of Gynae, BHU Varanasi, ex-president Varanasi Obstetric Gynec Society, president SFM UP chapter, president Varanasi Menopause Society, president UP chapter Obstetric Gynec 22-23, has organized very many conferences, has been an MD, MBBS examiner, DNB, MCI inspector, President Varanasi FMS, Founder Secretary IMS Varanasi. She is also the FAMS Fellow of Academy of Medical Sciences awardee. She has very many awards, a lot of national and international awards, many publications, has written several chapters, has guided 42 MD theses and 4 PhD theses. She has delivered many orations and guest lectures. Ma'am, we are really honored to have you here with us and would like to have your blessings for this program.
Madam, you are muted. Anuradha madam, please unmute. Yes,
Thank you, Dr. Patel.
Yes, welcome, madam.
I'm so thankful to Dr. Asha Jain and Dr. MC Patel to be invited in this Uttar Pradesh forum of all the societies you have mentioned. And it's my privilege that here I'm with you and going to have a very nice academic experience, that too with webinar, which I love very much to have it in webinar because that saves lot of time and money both. And we are focused to the learning, not here and there. So that is very much amazing for me, which we have learned in Corona period. And Dr. Patel, I appreciate you a lot. And you are going to be the contestant for Foxy next 2025. And my all best wishes are with you.
Thank you.
And you are such a hard worker, honest worker, which we all like you very much. And you have done excellent job in field of medical legal cases, how to tackle the cases so that we will not face it, and whenever we face it, then how to tackle further. So that's very, very important to understand. And Dr. Asha, I met her in Indore, and she is being also contestant after Ritu to be a chairperson for drug and other things. And my best wishes to Asha also. And our darling Ritu is with us, and Dr. Rajrika is also with us. And my other darlings, Dr. Reena Srivastava as a speaker, Dr. Radha Jinaji as my co-honor guest, and also Dr. Vibha Mishra, who is very, very close to me, and we love each other very much. And it's our society of UP Eastern part, which is very, very important. And our own Sadhna Gupta is there, which I like her very much for hard, honest work. Our colleague Dr. Nisha Rani is there as a chairperson, and one more chairperson, Dr. Sarita from Gorakhpur, and all the esteemed panelists are there, which I will like to listen them. And with the core of my heart, my best wishes to all of you. Thank you so much for giving me this time.
Thank you. Thank you, Anuradha madam. You are kind enough with us always to bless us for any of our academic activity. Thank you for sparing time.
Thank you, Anuradha ma'am. Thanks a lot. Nilesh, may I have Radha ma'am's CV, please? After receiving the blessings of Anuradha ma'am, we would like to receive the blessings of Radha ma'am. She is a graduate and postgraduate from MLN Medical College, Allahabad, retired from BRD Medical College as Professor Obstetric Gynae in 2008, has more than 100 papers in national and regional journals, has attended almost all UP chapter and national conferences of obstetrics and gynae and few international ones. She is the past president of GeoGS, President UPCOG 2015 to 17, and organized UPCOG 2016 in Gorakhpur. She has been felicitated by IMA Gorakhpur, Navdurga Award by Rotary Club Gorakhpur, Amar Ujala, Chief Patron of Foxy Saving Mothers Conference, Patron SAFOG Gorakhpur and Gorakhpur Obstetric Gynec Society, has been awarded UP Ratan in January 2022, awarded ICOG. And after retirement in 2008, she's still serving humanity actively. So though she's been retired for 15 years and she doesn't look it, she is still here with us, interested in academics and ready to bless us. So thank you, ma'am, and over to you for your blessings.
Thank you very much, Dr. Asha, for your nice compliments. I am really honored to be a part of this 173rd edition of Happy Learning Masterclass webinar today. Now it is the hard work of Dr. Patel and all of you that you are going to complete 173rd edition today, and it's great. I sincerely thank the program director, Dr. MC Patel, convener, Dr. Asha Jain, and coordinators, Dr. Rekha Rajendra Kumar and Dr. Ritu Khanna. The topics selected today are very important. And the first topic, CTG, proper analysis for optimum outcome by Dr. Rina Srivastava, is a very, very important topic, because we know we all as obstetrician should know the importance of CTG and how to read the CTG for labor outcome. And if there is any problem in CTG, then we should we should be able to recognize it early, and then we should be able to act accordingly. The second topic is also very important, which is panel discussion on MTP Act and its amendment. It is also very important, and everyone should know what is the MTP Act and what are the various amendments, because there are so many litigations today, and if we have any mistake, then we can have any litigation. And today, Dr. Patel, who is a, I can say, who is really a expert on medical legal field, is going to coordinate this topic of our panel, and all the panelists, they are also going to bombard on Dr. Patel, and Dr. Patel will have to answer all their queries. So I think it will be very good to have association with Dr. Patel and to look and to hear to him. Now I wish Dr. Asha Jain and Dr. Patel for their upcoming elections in 2025, and I think they are going to win it. So thank you so much.
Thank you, madam. Thank you, madam, for your kind
Radha
wishes
ma'am,
also.
the election will be in 2024.
24.
Yeah, it is for 25.
August 24.
Yeah, we are ready.
August 24.
We are
Thank
ready.
you, ma'am. Thanks a lot.
So thank you, Radha,
Nilesh
madam,
ji.
for sparing time. You are always with us to bless us in this type of activity.
नीलेश जी विभा जी का CV दीजिए. So thank you, Radha ma'am. And now I would like to invite Dr. Vibha Mishra for her address. She is an MS Gynae and works in Upahar Nursing Home, which is a limited company, Mahmoorganj, Varanasi. She has a President of India medal in MBBS, President IMA Varanasi in 2002, President Varanasi Obstetric Gynec Society previously, Founder Secretary IMS Varanasi. Areas of interest are medico-legal issues, infertility, recurrent pregnancy loss, and ultrasonography. She has presented many papers in national and international conferences. She has contributed chapters in books, magazines, journals, and TV shows. She is a member of the Prasar Bharati Board and District Social Welfare Committee, Varanasi, Ethics Committee, President and founder member of NGO Manishi Parishad, and many more awards and honors. She was also the organizing chairperson of AICOG 2012 at Varanasi. So welcome, ma'am, and we are eager to hear your blessings. Ma'am, you are muted. Ma'am, you are muted.
Welcome. Thank you, Dr. Asha, and welcome Dr. MC Patel and Dr. Asha. All these learned speakers before me have narrated so beautifully the today's topic. I would like to stress only 2 points. Today's topic are very important. One is when the baby is inside and you are treating, and second topic of medical legal importance when a doctor is treating. Learning both the things is of utmost importance. CTG we had been learning from our medical days, and now it has become a part of our real everyday working life. Interpretation and the acting accordingly saves many things. saves life and saves you from medical legal issues, which is the important thing of today's medical practice. And second most important topic today is medical legal issues. With every full stop, when you write a prescription or you talk to a patient, there is always a question mark: why, how, and when. If you can answer all those three things, you are always safe. But the problem arises when the other party is not ready to listen. And the same things, they are sweet when they want something, but when the things are done, they are at your heads. How to save yourself? The expert is Dr. MC Patel. And today he'll be answering the medical legal issues, questions asked by all of us and faced by all of us on this panel. I think the topic for today is very, very important, and we should give 100% our attention to listening to the answers given by expert Dr. MC Patel. Once again, I congratulate and I give best wishes to Dr. MC Patel and Dr. Asha for their new posts, which is to come in August 24. In advance, the best wishes again. Thank you.
Thank you, Eva madam. I still remember our long bond of relationship in 2012. I could recollect. We had a full day workshop on medical legal issues, and you were looking after that very workshop, and I was invited and to conduct that very workshop. And since then, you are always with me in any of my academic activity. So thank you, madam, for blessing me ever, and thank you for all the wishes.
I'll be inviting you soon again.
Yes, thank you, madam. Welcome. Always ready to be there.
Thank you.
Thank you, Vibha ma'am. Sir, with your permission, we would end the inauguration.
Yes.
So I thank Corona Remedies, our chief guests of honor, the conveners for being with us through this inaugural ceremony. And without wasting much time, we proceed to the scientific session. The first talk by Dr. Reena Srivastava ma'am. I would request the first chairperson to introduce the topic, the second chairperson to introduce the speaker, and the third chairperson to sum up. With this, may I have the CVs of the chairpersons, please? So we have Dr. Sadhna Gupta. I much prefer calling her Sadhna Didi. I called her yesterday and her daughter-in-law said that she will be seeing patients till 1 a.m. I was floored. How somebody can have that much of dedication and actually give that much time, it's beyond me. So welcome Sadhna ma'am. She is the co-chair CEPHOG NCD Committee 22-24, FOXY representative to CEPHOG 2018-21, VP FOXY 2016, ICOG Governing Council member for 6 years, corresponding national editor and peer reviewer of Jogi.
Asha is okay.
Okay. Welcome, Didi. Next, please. We have Dr. Nisha Rani Agrawal, ma'am, who's a professor of obstetrics and gynae and has a total experience of 39 years. She has received the Arthur Ashe Fellowship, New York, US. Areas of interest are labor analgesia and HIV in pregnancy, has 69 publications. Ex-President WOGS, scientific chairperson, UPCOG 2009, organizing secretary, AICOG 12, and organizing chairperson, UPCOG 19. Next, we also have Dr. Surita Karim. She is the Managing Director, Star Hospital Private Limited, Gorakhpur, Director at Safal Test Tube Baby Center, Gorakhpur, Life Member of IAG FOXY IMS, President of IMS Gorakhpur, Ex-President of GOGS and Inavil Club, Gorakhpur. She has organized the first live workshop on NDBH and first live workshop on laparoscopy and hysteroscopy at UPCOG Gorakhpur in 2003. She has been trained in ART and IVF in laparoscopy, hysteroscopy from Frankfurt, Germany. She is regularly organizing hands-on trainings certified by IIM Indore in Kritagya leadership program for frontline doctors and regularly participating as faculty in many national and international conferences. She has Wonder Foxian Award, Nari Shakti Samman by UP government, certification of appreciation by IIMA for outstanding work in COVID times, and she has contested as candidate in mayor election in 2012 and as candidate in MP election bypoll in 2018. So over to you, respected chairpersons, and requesting Sadhana ma'am to please introduce the topic.
Thank you, Asha, and my regards to all coordinators, conveners, all society, on all the faculties on this evening, and my special regards to Dr. MC Patel, and who has been a close friend since years, and we know how approachable and how grounded person he is, and we always, like, he is a friend of friend, and we always have him whenever any member wanted to approach him, especially in difficult situation. So my all best wishes to Dr. MC Patel, best Asha and Ritu. Again, it has been a real family, a long journey where we have worked together. And Asha, we actually didn't know. With my visit to Raipur at her home, we came to know that we have so much of common interest, and it was really heart-to-heart connection with her. And I hope that a spiritual person like Asha, like we in many professional organizations, because we all need the presence of such persons in every society, and they always have a important value in it. So with this, my responsibility is to introduce the subject. So cardiotopography, what he say? Two or three things very important about cardiotopography, that it is the fetus language which we need to understand what fetus is saying. So it is a aligned language, but this is a important what is the ups and downs, or flat, going very low or very high, and in what pressures intrauterine, what pressures fetus is. And it is the art to read the cardiotopography. Beside this, we have to have the differentiation between the cardiotopography, when what we are doing at particular time. It is 30 week, it is 32 week, what is the maternal issues, it is in labor, and what are the other things. So it is all, because we are the part of our all environment, and that environment has to be considered. When the fetus is stressed, sometimes it is normal and sometimes it is not. The beauty of the CTG is that it is the closest language which we have found that it is useful to understand what is going on in the fetus heart as well as the brain. So what we say, our Indian spirituality and the philosophy, that it is in our heart and our brain actually respond to that. So through the CTG, we can read the fetal neurological response. So finally, it is a autonomic and the neuronal maturity and the resilience to bear that pressure, what we read through the cardiotopography. Beside this, up to now, it is the best thing for our conference, for our academic lectures. We so many times, sometimes give a time to the thing which have not proven useful, like fetal blood sampling. It has not been proven good, good even in a Western country. So no, don't be defensive about it. We have been very good, while as an Indian OB-GYN that we have used the CTG as our armamentarium and not opted much for the internal CTG, which is actually it is invasive and have a lot of issues about it. So fetal blood sampling, fetal ECG, fetal pulse oximetry, all research says that it has not proven useful in various clinical scenarios. So let's understand the language of CTG, what fetus is saying to it, and what fetus wants from is going to operation theater, early delivery, or wait and watch. So for this, there is none other than what we can say, I can say elder sister is something very good. It is much more than that. Dr. Reena Srivastav is with us, and she is going to make clear that language and what action we wish to have after reading that letter from the fetus. So thank you very much, and Reena ji, we all are eager to listen to you.
Thank you.
Nilesh ji, may I have Reena ji's CV, please?
Regards to everybody associated with this conference, and all the best for the election of 24 to Dr. MC Patel and Dr. Asha. Reena is a very close friend of mine, and she is a very fine human being. It's a privilege to read out her CV. She is ex-professor and HOD, BRD Medical College, Gorakhpur. Past President UP Chapter Obs and Gynae, past President Gorakhpur Menopause Society, Fellow of ICOG, North Zone Coordinator SSNPP Foxy, past Treasurer Secretary President Gorakhpur Obs and Gynae Society, organized UPCOG 2003 and 2016 at Gorakhpur, organized NY Foxy at Gorakhpur, organized SAFOG 19 at Gorakhpur, organized numerous CMEs, workshops at BRD Medical College, Gorakhpur, authored chapters in many books. She has published many papers in national and international journals. Felicitated by Dainik Jagran for outstanding work for humanity. Also felicitated by Amar Ujala for the same. Felicitated in Global Health and Department of Family Welfare UP for outstanding planning in 2016. He has been associated with various social and academic activities, especially with work with NACO and SIFSA. And she is the chairperson of College Research Council, College Proctoral Board, and AIDS.
Thank you, Nisha. We can continue now. That's all.
Thank you.
Thank you, dear Sadhna, for the loving words, and thank you, Nisha. And first of all, I would like to thank Dr. Patel for this invitation and having me here in his Happy Learning classes. Thank you for that, Dr. Patel. And my thanks to Ritu and Asha for your calls and concerns, and welcome all the delegates. My wishes, best wishes, heartiest wishes to Dr. Patel and dear Asha for their future endeavors. So may I share my screen?
Yes.
Yes, ma'am.
Can all of you see it?
Yes, ma'am.
So I would be talking on cardiotocography. And just now, Asha has told me that you have only 20 minutes. So maybe I may be rushing on few slides. Cardiotocography, you all know, is a continuous electronic record of the fetal heart rate and uterine action obtained via an ultrasound transducer placed on the mother's abdomen. And well said by Sadhna, it is the fetal language which we have to understand when it is in utero. Why do we need a cardiotocography? Because there might be some unexpected complications that may occur during labor, even in patients, those who are not having prior risk. And it is always helpful to catch it early and expedite delivery. Before going for CTG, we should know that it is not a substitute for clinical observation, for clinical judgments, for an excuse for leaving the patient unattended during labor. It only assists in good judgments and clinical management. There are so many indications like antenatal maternal factors, maybe hypertension, preeclampsia, diabetes and all. Antenatal fetal factors, we all know these, I need not enumerate: FGR, prematurity, oligoamnios, disorders in umbilical cord blood flow diagnosed with Doppler. Maternal factors during labor could be bleeding during labor, intrauterine infections, then factors related to labor itself, maybe evidence of previous cesarean-induced labor, stimulated labor, fetal factors during labor, like meconium, evidence of disorders in fetal heart rate found during auscultation. So before taking a tracing, we should know how to take the tracings. And then maternal position is important, like lateral recumbent or half sitting or upright. And what should be the speed of the paper? And it should be horizontal with a speed of 1, 2, or 3 centimeters. 1 centimeter record, it is sufficient for analysis, and paper length is less, while 2 and 3 centimeters, the tracings are better evaluated. So which scale should we opt? One with which a healthcare professional is most familiar, because the tracing interpretation depends on the pattern recognition. Whether it should be a continuous or continuous monitoring, but continuous or intermittent CTG shows similar outcomes in low risk. So intermittent could be better. Then when should be continuous opted? When there is a vaginal hemorrhage, maternal pyrexia, abnormal fetal growth, epidural analgesia, meconium strained LICA, and so many things I have just enumerated. Admission CTG for all, it is not recommended, because then an increase in cesarean section rate was seen and no improvement in perinatal outcome was there. So admission CTG for all and continuous CTG for all is not recommended, but it is a standard of care in many countries. External fetal heart rate monitoring or internal. Internal, I don't think anybody over here is doing, because external fetal heart rate monitoring is more prone to signal loss, needs modulation, inadvertent monitoring of maternal heart rate, and signal artifacts, double counting, half counting, all this is there with external monitoring, but still it is considered to be sufficiently accurate for analysis. Internal monitoring is, you have to identify the presenting part, the structures might be injured, it needs a rupture of membranes, it is invasive, it can cause infection, and so it is not really opted. So the recommendation is routine monitoring, recording of acceptable quality, basic CTG features can be obtained, careful repositioning of the probe is carried out in second stage. In all atypical fetal heart rate tracings, maternal heart rate is ruled out. In any doubt, fetal auscultation can be done. So this is how we do go for it. Now, sometimes maternal heart rate monitoring may interfere with it, and separate some machines are incorporating it into their CTG, and it is useful in fetal heart rate block, useful in maternal tachycardia, useful in second stage of labor, and new equipments are coming up with it. Then monitoring of twins really will require dual channel monitor. And 2 years back, I have gone through the specifications of CTG, and they are coming out with it. Monitoring of twins, you can see the superimposition, and it is difficult to read. Then storage of tracing is part and parcel of the patient's record with name, address, date, time, place of recording, and speed. The first thing is how to analyze a tracing. For this, evaluation of basic CTG is required. Then overall CTG classification is done. Accordingly, a clinical decision is taken and action is suspected fetal hypoxia acidosis. And on the top of everything, limitation of CTG is also there. This we have to remember. So evaluation of basic features, we have to go for the baseline, variability, acceleration, deceleration, whether there is sinusoidal pattern, whether it's pseudo-sinusoidal pattern, fetal behavioral states, which is physiological, should always be accounted, and the contraction of the uterus. For this, we all know that the structured popular method is Dr. C. Bravado, which is having 7 items. So that nobody forgets. DR stands for defined risk, C contraction, BRA baseline rate, V variability, A acceleration, D deceleration, O overall impression. Then mean level of the, to go for the baseline, we have to take the mean level of the most horizontal and less oscillatory fetal heart rate segment. It is estimated for 10 minutes. And in this, you can see that the most horizontal segment is this and this. And this is giving nearly 140 beats per minute. So the heart baseline is 140 per minute. Then baseline value above 160 beats per minute lasting for more than 10 minutes is tachycardia. And it is there, we all know, in maternal pyrexia, intrauterine infection, epidural analgesia, and sometimes non-acute fetal hypoxemia. Bradycard, it can also be there in salbutamol, terbutaline administration, parasympathetic blockers like atropine. This is a trace of fetal tachycardia. The baseline is continuously touching around 180 beats per minute. This is also the same. The baseline is totally high and it is touching 180. So bradycardia, baseline value below 110 for more than 10 minutes. And in this segment, you can see that it is the most horizontal segment. It is showing a line touching around 100. Variability, it is oscillation in the fetal heart rate signal. Its average bandwidth amplitude of the signal in 1 minute segment. And to tell you, fetal heart rate variability, the first one is almost negligible variability. This is not normal. This is also less than 5, not normal. This is around 5 to 25. This is normal. And this is more than 25. So to calculate this, we take the height, the number of beats from the peak to the trough. You can see here from the peak to the trough, it is coming roughly about 12. So it is normal. And at various points on the horizontal scale, we take this and mean is taken out. And this in this graph, it is 20 per minute. It is normal. A decreased variability is seen in this trace. It is not more than 5 throughout. So this is a decreased variability. Increased variability, the bandwidth value exceeding 25 beats per minute, and probably when hypoxia acidosis evolves very rapidly. Like in this graph, you can see that between the two dots, there is increased variability, and same time, there is the contractions are almost bizarre, sometimes high, sometimes low. This patient was given oxytocin around 30 minutes back, and she started having this. Oxytocin was stopped, and you can see that it is coming to normal. Then abrupt increase in fetal heart rate above the baseline, that is 15 beats per minute. This is acceleration, and it should last for more than 15 seconds, but less than 10 minutes. It is a sign of neurologically responsive fetus, and fetus is not at all hypoxic. Absence of acceleration in normal partogram is insignificant. Acceleration never indicates hypoxia. And here you can see that acceleration showing a transient increase greater than 15 beats per minute. Deceleration, this is very important to note in any CTG. And we all know that it can be of so many types. Early deceleration, here it is mirror image. And this depth should not cross less than 100. That is early deceleration, and it is just because of compression of the head. This one is a late deceleration. It starts with the peak of just after the peak of contractions and ends here. It is late and may drop to less than 100. Variable it has got no relation with contractions, maybe before, with, after, anywhere in between. The decrease should be more than 15, often drops to less than 100. And this is a variable pattern mostly because of cord compression. The fourth one here, there is abrupt decrease of more than 15 beats per minute, often drops to less than 100, and may last for, if it lasts for more than 2 minutes, it is a prolonged deceleration, and this is not normal, it is pathological. Here, this is a case of early deceleration. You can see with each contraction, there is deceleration, and this baby delivered with an Apgar score of 8 and 9 at 1 and 5 minutes. Then late deceleration. You can see the example of late deceleration here. This is a very beautiful picture. You can see here the late decelerations. They are starting after the peak of uterine contractions. And this is a case of late deceleration. Here, it is all there. And this patient came with 6 centimeters dilatation, head at -2, liquor was stained with meconium, and immediate cesarean section was done. The outcome was male, live baby, but the Apgar score was 2 at 1 minute, came to 8 after 5 minutes, and had meconium aspiration, for which it was treated. A prolonged deceleration, a deceleration that is lasting for more than 2 minutes. There is hypoxemia, chemoreceptor stimulation, decreased fetal heart rate, and this is not normal. This is a prolonged deceleration, you can see. And at 3 minutes, we have to call. We all know the rule of 3, 6, 9, and 12. I'm not going for it. This is a prolonged deceleration. This case, just before this dot, you can see this patient had a cesarean in the previous pregnancy. She was undergoing labor. The cervix was 8 centimeters with clear liquor before this dot. And after that, what was found that there was a sudden fall in the fetal heart rate, and it is not resuming back. And along with that, you can see the uterine contractions are also vanishing. So it was suspected rupture. It was open. It was a rupture uterus, and it was a fresh stillbirth. Variable decelerations, umbilical cord compression, you all know. You change the position and you might get the normal one. These are the very good pictures of variable deceleration. No relation with uterine contraction. The peak may go up to 90 or so, may go up to say 50 or 60, whatever. This is a bizarre type of deceleration, which is not related with hypoxia. Sinusoidal pattern is, you can say, regular, smooth, undulating signal like a sine wave with an amplitude of 5 to 15 beats per minute and lasts for more than 30 minutes and coincide with absent acceleration. It is not normal. May be present with fetal anemia, anti-de-aluminization, fetal maternal hemorrhage, 20-20 transfusion, ruptured vasa previa, and this is the example. There is no variability into it, very consistent type of sine waves present. It is not normal, pathological. This is also the same, and the baby has to be taken out. Then there can be a pseudo-sinusoidal pattern, like sinusoidal pattern, but jagged appearance, sawtooth appearance, just like sine wave, duration not more than 30 minutes. When the patient mother has been given analgesia, and fetal mouth movements, suckling movements, all they can cause this type of pattern. This is not abnormal, and the duration of stay is shorter than pseudo-sinusoidal pattern. It is the point to differentiate from true sinusoidal pattern. This is the example of pseudo. It is having a jagged appearance. Then we should know about the fetal behavioral states. The fetus sleeps also. And in deep sleep, that which may last up to 50 minutes, there is a baseline which is stable, very rare acceleration, no acceleration. There can be borderline variability or low variability, but that doesn't mean that the fetus is not neurologically active. We have to wait for another CTG to take. When the baby is in active sleep with rapid eye movement, the CTG is almost normal. There is good variability. Moderate number of exhalations might be there. And active wakefulness, it is rare. Large number of exhalations would be there. Normal variability is there. Acceleration so frequent that may cause difficulty in baseline estimation. So fetal behavioral states, presence of different behavioral states means good fetal neurological response. That means fetus is neurologically active. Uterine contractions, I'm not going into the detail. You just see this chart. There are 2 to 3 contractions in 10 minutes period. We have to count. They are normal up to 5. If they exceed 5 in 10 minutes and in 2 successive 10 minutes, then it is known as stachystically. Mostly when some oxytocin and this type of drug is being given. Then to analyze the tracing, after seeing all this, we have to analyze after looking after the basic CTGs. Changing nature of CTG signals, re-evaluate every 30 minutes. We have to analyze it, whether it is normal, whether it is suspicious, whether it is pathological. So normal, that means fetal heart is 110 to 160, variability 5 to 25, decelerations either none or early or variable. Interpretation is reassuring and no intervention is required. Suspicious means baseline 100 to 109, 161 to 180. Variability is less than 5 or more than 25 for say 30 minutes and 15 minutes. Deceleration, if it at all it is present, variable deceleration, and for 90 minutes, variable deceleration with the in 50% of contractions, and late deceleration is in over 50% of contractions. So to interpret, we cannot interpret it normal or it is pathological. We have to see for the causes which can be reverted back, and maybe with reversion of those causes, it comes to normal. So it needs an observation. Pathological, all the things I have just enumerated, below 100, 180, variability is less than 5 or more than 25, say for 25 minutes. Deceleration, a variable with in 50% of contractions for 30 minutes, late deceleration for 30 minutes, prolonged deceleration for 3 minutes. Interpretation is probably the fetus is having hypoxia, may go into acidosis, and immediate. Just now Sadhana was talking of fetal blood sampling, except really we are not using it and it is not of much value. At this juncture, we should take out the fetus depending upon the stage. So all features, when they are reassuring, it is normal. When one abnormal feature is present, it is suspicious. When two reassuring features are present, like in the suspicious variety, if 2 points are present, then again it is pathological. And one pathological feature is present, it is pathological. So CTG needs to be integrated with other clinical informations like gestational age, medication, stage of labor. Comprehensive interpretation is important. It is not that we are going to treat the paper, the CTG paper. We are going to treat the mother, and it needs a comprehensive analysis. For the suspicious ones, I can say a few things like if it is a suspicious CTG, look for underlying cause. If defined, reverse the condition. That will give oxygenation to the fetus and CTG might be reverted. If excessive uterine contractions, stop oxytocin, remove prostaglandins, give trocholysis. For supine position, yes, you can change the position of the fetus because there might be aortocaval compression. There decreases perfusion. Then transient cord compression is there. Change the maternal position. All this may bring or revert back the findings. Once it is not reverted, it will go to pathological. So we have to be aware of limitation, make safe use of CTG, and the limitation of CTG is also there. That can be inter or intra-observer disagreement. Shortly after normal CTG, what does it predict? It will predict that hypoxia, acidosis is not there in the fetus. And suspicious and pathological CTG, there is strong association with hypoxia, but limited capacity to predict metabolic acidosis. So the message is that CTG during labor is mainly required for high-risk cases as continuous. Intermittent monitoring with CTG can be done in low risk. We need to know the basic features of CTG. Then we have to categorize it as normal, suspicious, or pathological. Normal, no intervention required. Pathological, we need to expedite delivery. Suspicious, we can be conservative and follow the case. So we have to be aware of limitations and make safe use of CTG. Thank you so much.
मैसेज नहीं, वो मैं दिखाऊंगी आपको.
Thank you, Dr. Reena. Should I sum up now, or the
yes.
Dr. Nisha is...
Yes, with your expert comment, madam.
Okay. Thank you so much, Dr. Reena. That was a beautiful talk. And first of all, since I've got the opportunity to speak I must thank Dr. Patel and Dr. Asha and Dr. Ritu Khanna for including me as a chairperson in this talk by Dr. Reena. To sum up, now we all know that CTG is an invaluable tool to all of us obstetricians who are dealing with the patients of obstetrics, and who, especially the high risk patients, where we are expecting, wanting to give a good result. So right from where Dr. Reena has given us the indications where we can do the CTG. So while we do the CTG mostly for the high risk patients and mostly at beyond 32 weeks, we can say. So especially any patient who is coming in with the complaining of decreased fetal movements, or we are expecting a IUG, we are monitoring an IUGR baby and we want to see how it is behaving inside. Often we are using these ammunitions in our armamentarium. So while interpreting what Dr. Reena has said, that the rate has to be checked very carefully, the tachycardia and the bradycardia, and the baseline, we should know how to take the baseline. Then she talked in detail about the variability, like there is a acceleration with movement is a normal phenomena. Absence of acceleration is insignificant. The prolonged deceleration is a pathological phenomena, and late deceleration is a suspicious, and it may lead to pathological phenomena. Variable deceleration, if we are getting, then we can change the position and do another CTG and see if that is corrected. And the variability of the deceleration can be either normal or it can be a suspicious phenomena. Often we have seen that when the fetus is sleeping, we get the sinusoidal, pseudo-sinusoidal type of a pattern or a sinusoidal pattern, and we are confused whether this is a baby which needs to be taken out or not. So always we will repeat the CTG after 1 hour or give a good tap. And an acceleration with movement is a sign of a healthy and normal fetus who has got good neurological response. So it is a good thing, and we can rule out any other abnormality in that case. So overall, the talk is very comprehensive, and we have good take-home message that how to interpret the result of the CTG. It may be classified as normal, suspicious, or pathological. And intermittent monitoring with CTG in high-risk cases is the best tool any obstetrician can have. During labor, of course, many centers have been using the CTG to check the fetal acidosis, etc. But I don't think it is very commonly used in the private practicing doctors. But for a very, very precious pregnancy who wants to go for a normal labor, it is a good tool to have monitor the fetus in the second stage of labor. So I think it is a good subject which Dr. Ritu has brought us to focus upon. And thank you very much for letting me be a part of it.
So, congratulations, Reena Madam. You have very nicely covered the subject. And as far as this infant mortality part is concerned, because by 2030, WHO and central government has given us a target, it should be less than 12. And maternal mortality should be less than 76. So, if we have to go with that target, then CTG would be the one most part or instrumental rather, because in our medical legal practice, whenever we face this type of cases in court of law, fresh stillbirth or so, first question usually asked on part of prosecution is, was it preventable? And usually you cannot say no, because almost many cases in our obstetric practice are preventable. So to prevent all this mishap and to not to face litigation in future, CTG would be much instrumental rather, and it should be very nicely interpreted to have optimum outcome as far as perinatology is concerned. So thank you, Reena Madam, for covering the subject very nicely.
Thank you, sir.
Yes.
Thank you, sir. Thank you, Reena ma'am. I'm really floored. You know, you really did it. So we are very much on time with the chairpersons concluding and speaking, and still we are on time. And we have 1 hour for the panel discussion. This is my request to all the panelists that if some panelist is not there, then somebody else may take the question. It will be on display. So the panel is thank you, Sadhna ma'am. Thank you, Nisha ma'am. Thank you, Surita ma'am. And thank you, Reena ma'am, for the first scientific session. And now we start the panel. Somebody has logged in from 2 devices, requesting to log out from one because it's creating a lot of disturbance. So I would like to introduce Dr. MC Patel, sir. He's a consultant obstetrician, gynecologist, and medico-legal counselor, Vice President FOGSI 2018, Organizing Secretary of AICOG 2017. He was the chairperson of Ethics and Medico-Legal Committee FOGSI 2011 and 13. He stopped being the chairperson, but he remained in ethics and medico-legal work and has been a backbone helping every FOGSian in times of need in medico-legal problems. So thank you, sir. And now he's the honorary state secretary, state organization of SOGO, organizing chairperson MMCon 2018, honorary member, National Inspection and Monitoring Committee, PNDT Act, honorary member, State Supervisory Board, President, Ahmedabad Obstetric Gynec Society, has held many positions, does a lot of NGO work, which is really quiet and he doesn't like to talk about it. But in the Northeast, he's been going for more than 10 years doing NGO work and taking health care to the underprivileged women over there. That's me. I've already been introduced. And now this is a short video from sir.
शुभं करोतु कल्याणं आरोग्यं सुखसंपदम्.
Respected seniors and dear
It's not
colleagues,
visible, ma'am.
serving FOGSI for years together on this auspicious day, with folded hands and down head, I seek your guidance. There is some connectivity issue. Dr. Asha?
Yes, it is not, pictures are not seen.
Yes, yes.
नहीं दिख रहा था सर?
नहीं.
बिल्कुल नहीं दिख रहा.
अब बताइएगा यदि अब चल रहा है तो.
Screen was totally blank. Blessings and support to endorse my candidature for the post of FOGSI President year 2026, election year 2024. Consistently working for FOGSI and trying to visit even smaller societies and to assist our common FOGSian friends in any given situation, I have tried to serve FOGSI. I assure to serve FOGSI in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
These are our panelists, and I will be introducing each panelist as they come along. So first, before we have the panelists, I would like, as an introduction to the MTP Act, ask sir a couple of questions. Sir, what was the need of the MTP Act, and when did the first act come, and for which indications?
So before this MTP Act was enacted and came into practice in 1971. So before that, any abortion services were considered illegal, and any person doing termination of pregnancy were tried under Indian Penal Code 1860. So due to that, registered medical practitioner who were well versed with the work, they were not doing due to this not allowing by law. So criminal abortions were very much in number in those days, and due to their morbidity and mortality was also observed. So government came up with forming one committee, Shantilal Shah Commission, in 1966 or so. And in those very committee, 50 persons were doctors member, and other 50 persons were influenced by Dr. Radha. So this MTP Act is doctor friendly. So in 1966, this act was introduced to government, and it was came into existence in 1971. And after this act was enacted in 1971, rules and regulations related to that very act were introduced in 1975. And then after this act is in existence as far as MTP services are concerned. Asa, you are muted. Please unmute.
We have Dr. Seema Pandey, ma'am. She is the president of Azamgarh Obstetric Gynec Society. She writes poetry, and she is here but would not be able to speak. So I request somebody else from the panel. Seema ma'am, if you can take your question, you're most welcome.
Okay, hi Asha, hi
Yes,
Dr.
welcome.
MC.
Namaskar, ma'am.
Yes,
Good evening,
welcome, Seema.
namaskar. I have some network issue, that's why I was saying I won't be able to. But yeah, it is very interesting program. Congratulations for doing it. And what are the important provisions of this MTP Act, Dr. Patel? And was there any punishment included in the act? I'm speaking both the questions together so
Okay.
that if I lose the connectivity, you can.
No issue. Welcome. Welcome, Seema. As far as provisions of this act, MTP Act is concerned, so two main provisions. One is place where MTP can be done, and person who can do MTP. So any government hospital or any hospital aided by government government, or any place registered or approved by district level committee are the approved places as far as MTP services are concerned. And person who can terminate pregnancy, any registered medical practitioner who is allopathy graduate and registered in respective medical council of the state and having requisite degree and experience can terminate pregnancy. Say, for example, any postgraduate degree, diploma or DNB in OBGYN can terminate pregnancy as far as provision of MTP Act is concerned. And there is a stringent punishment if these two provisions are violated. If person who is not qualified and terminates pregnancy, and person even if he is qualified and terminates pregnancy at unapproved place, then there is a provision of imprisonment which may extend from 2 years to 7 years and fine or both. So the place should be registered and person should be qualified. These are the two main requisites or provisions rather as far as MTP services are concerned. There are other means also. We will discuss one by one when we approach this panel. Yes, next.
Thank you, sir. Thank you, Dr. Seema. This is Dr. Archana Messi. She is the secretary of Azamgarh Society, sir. She loves gardening and traveling. And can you see this?
Yes.
So she has sent me a video of the sea, but I just took a screenshot. And this is her garden. I would say her photography is equally good.
Yes,
So,
very good.
welcome, Dr. Archana.
Hello, hello. Can everyone hear me?
Oh, yes. Welcome.
Thank you, Dr. Asha and Dr. MC Patel, for inviting me for this prestigious program. And I'm honored to be here. And I already told you I am quite in awe with you guys doing so much work. And I would like to ask a question. How effective was the initial act in the purpose of decreasing unsafe abortions, and how many times was it amended and why?
So, main purpose of this MTP Act was to save registered medical practitioner from purview of IPC if he practices MTP services in accordance with MTP Act. And second thing, to challenge or to prevent rather unsafe abortion or criminal abortion. So with this MTP Act enactment, it was given power to registered medical practitioner to practice termination of pregnancy. So, and it was declared on part of government that it is safe, it is free in government institution, and it is confidential. So with this, patients which were going to quacks for criminal abortion, they are now coming to a registered center for termination of pregnancy, and mortality and morbidity related to unsafe abortion or criminal abortion have decreased with this amendment of MTP Act. And as far as amendment is concerned, first amendment came in 2003, because previously to register any center, application was to be made to respective government of the state. But now power has been delegated to district level committee. So district level committee can also visit nursing home, and if all the requisites are fulfilled, then registration of center can be granted by district level committee also. And one more amendment came in recent past in 2021 only, and there are so many provisions in that amendment also. We will discuss one by one as this panel progresses. Thank you.
Thank you, sir. Now we have Dr. Savita Agrawal, ma'am. She is the president of Gorakhpur Society. She does short story reading and she loves gardening. So you can see glimpses of her garden, sir. अब गोरखपुर जाएंगे तो बैठिएगा.
बिल्कुल. नहीं, इनके लिए गोरखपुर विजिट करना पड़ेगा. सविता मैडम.
Thank you, Dr. Asha Jain.
Yes.
Thank you, Dr. Asha Jain and Dr. Ritu Khanna and Dr. MC Patel for inviting me as a panelist in this session. So I wish you, Dr. Patel and Dr. Asha Jain, for the forthcoming election for the best wishes. And now I would like to ask that. Now I would like to know the latest amendments in MTP Act and how does it benefit doctors and the women?
So in recent past, that is in 2021, this amendment came, and there are so many new provisions which are in favor of patient as well as in favor of doctor. One very important amendment which came, indication, that is failure of contraception. Of course, it was also there in a previous act also, but it was available to married woman and to her spouse. But now with this amendment, word married woman is replaced by any woman, and word her spouse is replaced by her partner. So now this indication, that is failure of contraception, is available to any patient irrespective of her marital status. So it is one good amendment. One more amendment came, that previously termination of pregnancy was permitted up to 20 weeks of pregnancy with opinion of 2 registered medical practitioners. But now with this amendment, it is available up to 20 weeks of pregnancy with opinion of only 1 registered medical practitioner. So with opinion of 1 registered medical practitioner, with given indication, pregnancy can be terminated up to 20 weeks. more than 20 weeks and less than 24 weeks. It is one more amendment. Previously, more than 20 weeks were not permitted, but now it is permitted with some special indication. And in those very indication, with opinion of 2 registered medical practitioner, pregnancy can be terminated up to 24 weeks of pregnancy. More than 24 weeks of pregnancy, if there is a fetal congenital anomaly which are incompatible with life of fetus, then with opinion of medical board, pregnancy can be terminated beyond 24 weeks of pregnancy and up to any given gestational age. So medical board is conferred with the power to opine in this type of situation whether pregnancy can be terminated or not. And one good amendment in favor of patient in this respect. Previously, whenever pregnancy was more than 20 weeks, to have a permission to terminate pregnancy, one had to go to Honorable High Court with writ petition. But now it is available with a medical board's opinion. And in past, Honorable High Court were referring case to medical board only. But time limit was not fixed. In one of the case, it was happened, opinion was shouted at 24 weeks of pregnancy, and when opinion came, pregnancy was 36 weeks. And it was published in Hindu newspaper also. So with this amendment, now medical board is under obligation to opine within 3 days. As soon as medical board receives any application to seek opinion whether pregnancy can be terminated or not, medical board will opine within 3 days. And once there is an opinion from medical board that pregnancy can be terminated, then that very pregnancy should be terminated within 5 days. So this 2 amendment, to opine within 3 days and to terminate that very pregnancy within 5 days, are 2 good amendments in favor of patient. And as far as one confidentiality part is concerned, previously it was also there in that MTP Act, but punishment for that was only fine of ₹1,000. But with this amendment, punishment has become little stringent one. So if there is breach of confidentiality of any patient who is undergoing MTP, now there is a provision of imprisonment of 1 year and fine and or both. So these are some amendments which came in 2021, and they are much more in benefit of patient as well as in doctor also, because previously many a times more than 20 weeks pregnancy, we were observing that fetus is having congenital malformation which are incompatible with life of patient, and we were not given permission to terminate pregnancy beyond 20 weeks unless permission from Honorable Court. And one more part was that in case of minor, in case of rape victim, even in this type of situation, in mentally retarded patient, if pregnancy is more than 20 weeks, previously it was not allowed. But with this amendment, now up to 24 weeks of pregnancy, in all these conditions, with opinion of 2 registered medical practitioners, one can terminate pregnancy. So it is much more in benefit of patient as well as practicing doctor. Yes, further. Next.
Thank you, Dr. Patel. You have very nicely said.
Yes.
Hello.
Yes,
Hello.
yes.
Thank you,
This is
sir.
this is a very good amendment, so that pregnancy can be terminated after 24 weeks. Sometimes it is diagnosed late,
Yes.
when the fetus is not viable afterwards, then it can be terminated easily.
Yes, ma'am.
But one thing I want to ask,
Yes.
if how can we maintain the confidentiality of the women if we will keep the case for in front of the state court?
Ma'am, that question is coming later.
Okay.
Acha,
So we
okay,
will
That
take
question
at
is
that
coming
time.
later, ma'am.
Yes, we will take
Okay.
it.
So, sir, now we have Dr. Alpana. She is the secretary of Gorakhpur Society and loves dancing. She's here in the center.
Good.
So, Dr. Alpana,
Congratulations.
Yes, ma'am.
over to
Thank you. Thank you, ma'am, Dr. Ritu Khanna, ma'am, Dr. Patel, Dr. Asha, ma'am, for making me the part of this panel. And I'm really honored to be here. So my question for the sir is, What are the violations of the Act commonly seen in the court? And are medical abortions also covered under the Act?
Yes. So, address to your first question, violation
Yes.
of Act commonly seen in court of law. Many center is not registered, person is not qualified, consent which is to be taken in Form C, which is prescribed form. So consent is not taken in Form C, opinion is not formed by registered medical practitioner. So these are some areas as far as violation of Act is concerned, and they are addressed in court of law, and our Foxian friends or our obstetrician friends are into trouble. As far as medical abortion are concerned, it is accepted method of termination of pregnancy. So even if you terminate pregnancy with medical method, then also it will come in purview of MTP Act. So all the provisions will be applied. So you will have to go for opinion formed in Form 1, and you will have to take consent in Form C. So even if you go with medical termination of pregnancy by medical method, all the requisites related to MTP Act's provision will have to observe.
Thank you, sir. Sir, have you also answered the second part, medical
Yes,
abortion?
yes, I have answered. I have answered.
So we have Dr. Shikha Sachan, ma'am, who is the secretary of Varanasi Society, and she loves dancing, but she didn't send me a photo. So, Shikha, ma'am, over to you now.
Thank you so much, Asha, ma'am. Thank you so much. And this
I
has
waited for
reminded
your
me.
photo.
Yes, ma'am, definitely. This has reminded me to take a photo next time when I perform any dance. So all pictures which I had taken had my conical mouth and my expressions like that. So this has reminded me. Next time I'll be taking a very nice picture before dancing. Thank you so much, sir, for inviting me for the session. And it's always great honor to be a part of your sessions. And there's so much of positivity involved with Asha ma'am having a novel way of introducing us with our hobbies. It's really a wonderful experience. Thank you so much, ma'am. And my question for today is, what are the forms to be filled and the provision of personal privacy of the lady under this act, sir?
So as far as this MTP Act is concerned, there is a long list related to forms. So starting from A. Form A is a prescribed form. Whenever one wants to get her clinic or center registered, then we will have to apply in Form A. If registration is granted, then certificate of registration will be given in Form B. It is again prescribed form. One form is Form C, that is consent of patient undergoing termination of pregnancy. So we have to take consent in that prescribed form, that is Form C. One more form is Form D, and this is form given by medical board. Whenever we have referred patient before medical board for opine, to opine when pregnancy is more than 24 weeks, medical board is under obligation to opine in prescribed form, that is Form D. So these are the forms A, B, C, D. Same way, Form 1. Form 1 is opinion. Up to 20 weeks of pregnancy, one registered medical practitioner will form opinion in prescribed form, that is Form 1. Form 2. Form 2 is prescribed form for intimation to appropriate authority of submitting the report at the end of month. So in Form 2, it is also prescribed, one more prescribed form. And in all those forms, we have to give only statistic. No information of any patient who has undergone MTP is to be given in Form 2 to appropriate authority. Say, for example, in month of November, in your hospital, total number of MTP, say, for example, 25. How many of up to 12 weeks of pregnancy? Say, for example, 10. From 12 to 20 weeks, say, for example, 5. So that way we have to give with statistic number only. No personal information of any patient is to be submitted to appropriate authority in that very form. So there is no breach of privacy in that way, because we are submitting only numbers, not any personal information of patient. So that is Form 2. One more form is Form 3, which may call it admission register, which may call it MTP register. But in eye of law, as far as MTP is concerned, Act is concerned, it is Form 3. So in Form 3, all the details of patient is entered. So once it is decided that pregnancy of that very patient is to be terminated, that serial number, name of patient, address of patient, age, gestational age, who has formed opinion to terminate pregnancy, who is going to terminate a pregnancy or who has terminated the pregnancy, any contraceptive methods patient has adopted after termination of pregnancy, by which method pregnancy was terminated. So all the details are given in Form 3. And once all this information entered in Form 3, number is given to the patient. And that very number is very unique to that very patient. So after that, all the correspondence related to that very patient will be done by only number which is given to that very patient in Form 3. So this is one more form. There is one more form, that is Form E. So when pregnancy is more than 20 weeks and less than 24 weeks, two registered medical practitioners will have to form opinion. And they will form opinion in Form E. So this is one more prescribed form. So all these forms are available on net. If you type MTP Act, and all this form will be available there on way. So we are under obligation to fill all this form in respective cases, not to end up into any litigation related to MTP.
Thank you, sir.
Sorry.
Thank you. Now we have Dr. Ambar Khan, who's the secretary of Jaunpur Society. And you can see she loves gardening and she loves drawing and painting.
Good.
Thank you, ma'am. Good evening and greetings to all the respected seniors and my dear friends. Sir, my question to you is who can be shown the documents of the lady and who is the authority who can give orders to us to show the papers? And my next question is, MTP form is submitted online to district authority. Then what about the privacy of the patient?
So to address your first question, as far as documents are concerned, so just I mentioned about Form 3. So once we enter all the details of patient and number is given to the patient, we usually go with number. But there are two conditions. In those two conditions, we can open this register and can have information of the patient. One condition is if patient is working woman, and if she wants certificate to grant leave from her job after this MTP, then she can ask her from the certificate, and we can very much issue certificate that patient was terminated pregnancy by us and she is advised rest for 7 days, 10 days, whichever we advise. But whenever we hand over this certificate, we are handing over this certificate to the patient. So whenever we give that very certificate to the patient, we are not violating, we are not breaching confidentiality of patient. Patient may give that certificate to employer to grant leave. But to be on safer side and to be much conscious about this, we can give one separate letter to employer also. This is confidential matter of patient, and you are also requested not to disclose information of this patient. So our job is over as far as this part is concerned. One more area under authority of law. So appropriate authority who has assigned this power can inspect that very register, and he can see all the documents related to MTP. And one more part, if at all there is litigation, then investigating officer is also conferred with power to inspect that very register. Otherwise, this register cannot be open and all the information should be kept confidential. your second question, as far as online submission is concerned, in very few states, online submission is started. Otherwise, it is by physical form also, only. And I mentioned prior also that as far as submission of our data in Form 2, this is prescribed form, I mentioned prior also. And in that very form, no personal information of any patient is to be revealed. We have to go with only statistic. So even if we submit online, then also we are not breaching any confidentiality of any patient. So nothing to worry on that part also.
Thank you, sir. Thank you.
Yes.
Thank you, sir. Now, we proceed to Dr. Kusum Verma, ma'am, who loves traveling. As you can see, traveling to various places. And she's the president of Mau Obstetric Gynec Society. Over to you, ma'am.
Yes, Kusum, madam.
Good evening, sir.
Yes.
Thank you for making me part of this. I am highly thankful to Dr. MC Patel, Dr. Asha ma'am, Dr. Ritu Khanna, who make me the part of this prestigious discussion. And my question, with OTC availability of MTP pills, where does the reporting on MTP stand? And my second question is, what is the role of gynec when such a baby lady comes with retained products of conception?
So first I would like to answer your second question. If it is retained product, then it is a complication. So it doesn't come in purview of MTP Act. So you have to simply treat as you treat any complication of any procedure. So no need to go for Form C, Form 1, whichever. You can very well manage that very patient. As far as your first question is concerned, of course it is available, but it is not officially available on OTC because it should only be available on prescription. But chemists are a very notorious person and they entertain demand of patient on OTC. But we, if at all we complain to Food and Drug Department, then they can take action. But usually nobody goes for a complaint as far as this OTC availability of MTP pills are concerned. Long back it was taken on part of IMA and on part of Foxy also. But for some time it was very strict as far as this availability is concerned. But then after again it has become liberal one. So if one complains against any particular chemist with proof, then Food and Drug Department has to take actions against him. And if it is proved, then it will be very difficult for that very chemist or pharmacy to face in court of law. Because whenever he supplies any medicine related to this MTP pill or termination of pregnancy, he is not qualified person, his pharmacy is not registered. So there is a provision of imprisonment of 2 years to 7 years. And if it is proved that he has supplied medicine without prescription of registered medical practitioner, he will be in trouble.
Thank you, sir.
Yes.
Thank you, sir. Thank you, Dr. Kusum. Now we have Dr. Ekika Singh, who is the secretary of Mau Society. She loves dancing and singing. I have not been able to see her here. Dr. Ekika, are you there? Ma'am, if she is not there, Savita ma'am, would you take the question, please?
Yes, okay. I can take.
Oh, yes.
Yes, ma'am.
Little deformity discussed is normally scan can MTP be done?
Yes, if fetus is having lethal deformity, or we can say congenital anomaly which are incompatible with life of fetus, pregnancy can be terminated. Up to 20 weeks of pregnancy with opinion of one registered medical practitioner, up to 24 weeks, more than 20 and less than 24, with opinion of 2 registered medical practitioners, and if pregnancy has advanced 24 weeks, with opinion of medical board, we can terminate pregnancy if pregnancy is having congenital fetal malformation, which are lethal one.
My second question is, non-lethal anomaly detected at 27 weeks. Can MTP be done? Under which provision and what is the legal procedure involved?
So, if pregnancy has advanced 24 weeks and fetal anomaly is non-lethal, then without permission of honorable court, we cannot terminate pregnancy. If it is lethal one, then only we can terminate pregnancy with opinion of medical board if pregnancy of 27 weeks. But if it is non-lethal, then we will have to go for seeking permission before Honorable High Court.
Okay, thank you, sir.
So we have Dr. Meena Jain. She is the president of Mirzapur. It has been difficult to connect to both the president and secretary of Mirzapur. So I don't think they are present here. And I request somebody else to please take the question.
May I take?
Oh, yes. Oh, yes.
Who gives consent in a major lady? Is a partner consent required?
No, if patient is adult, if patient is mentally sound, only and only patient can give consent. So nobody else can give consent on her behalf. And as far as provision of MTP Act is concerned, consent of partner is not required. Legally, it is not required.
Okay, thank you, sir. Is a separate informed consent along with Form C required?
So, as such, we are under obligation to take consent in Form C. It is prescribed form. But it is a very simple form. In that very form, it is only written, I give my permission to terminate my pregnancy. So, it is not informed consent, because whenever we go with any consent, it should be informed one. Patient should have knowledge about your procedure, about probable complication, about outcome, about prognosis. So, Form C is not informed consent. So, we will have to go with 2 consent. One in Form C, it is very much required legally, and one more consent, that is informed consent. And for that, you have not to worry. You have to simply visit Foxy website. On Foxy website with name Uniform Foxy Consent are available on Foxy website, and with 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent for different operation. And in those very 30 different consent, we have prepared consent for termination of pregnancy also. So by both method, by medical method and by surgical method, both consent are available on Foxy website. You can download from Foxy website and you can very well utilize. It is available for cesarean section also, hysterectomy also, abdominal, vaginal, endoscopy, cervical and cerclage, transferring patient to higher center, consent for anesthesia, consent for blood transfusion. So, common 30 condition or situation, we have prepared consent, and it is available on Foxy website.
Thank you, sir.
Yes.
So now this is for Dr. Meena Vishwakarma. She's the secretary of Mouse Society. Again, she's not logged in and could not be contacted.
So can I take the
anybody
question?
can take.
Dr. Asha?
Yes, ma'am.
Bharti here.
Yes, Bharti can take.
Namaste, Dr. Patel, sir.
Yes,
and
yes,
thank you
welcome.
for having me here. And the question is, any interesting cases with learning for us on the mistakes we need to avoid? Any specific things? And the second question is, your final minimum recommendation to avoid litigation in MTP.
So before I answer, let me introduce Dr. Bharti. Bharti is President-elect of Kasoga, that is Karnataka State Association, and she is from Hassan. She is our guest faculty and guest panelist. So question is, any interesting cases with learning for us on the mistakes we need to avoid? I would like to mention one very interesting case which happened with city of Ahmedabad only. In 2003, MTP was done. Center was registered, person was qualified. So he went with all this formality and pregnancy was terminated. In 2004, there was quarrel in the family. So patient filed a complaint against in-laws that it was forceful abortion without my consent, against my will. So doctor was called in court of law as an expert witness, and court asked from doctor to provide records about Form C, that is form of consent, Form 1, that is form of opinion. And for any reason, doctor couldn't produce those records in court of law because doctor said that I terminated pregnancy with medical method. It was OPD procedure, and in OPD procedure, we do not preserve record. And that way, our answer was very casual in court of law, and court ordered to arrest doctor from court only. You won't believe, he was arrested, he was behind the bar. After 3 days, party had a compromise, case was withdrawn, and then only doctor was out of the bar. So imagine the situation, merely not providing records before honorable court, that is Form C, Form 1, he was held responsible and he was behind the bar. So we cannot afford this type of situation. So we should be very careful whenever we practice termination of pregnancy in any of patient, and all the provisions of MTP Act we have to observe. So take consent in Form C to form opinion. Our center should be registered, person should be qualified. So we should observe all these provisions, because under Section 3, we are given so much power as far as this MTP Act's part is concerned. Under Section 3, it is very specifically mentioned that notwithstanding anything contained in Indian Penal Code or any law time being in force will not be applied to registered medical practitioner if he has terminated pregnancy in accordance with provision of MTP Act. So if we have terminated pregnancy in accordance with provision of MTP Act, then we are out of purview of IPC. Otherwise, there is a provision in IPC section 312 to 316. And if we have not taken consent in Form C, we were held responsible under Indian Penal Code section 313, termination of pregnancy without consent. And there is a provision of imprisonment of 10 years, and one cannot afford. So we should be very careful whenever we go for termination of pregnancy in any case. So my recommendation, we have to strictly observe. We have to strictly comply with the provision of MTP Act 1971.
Thank you, sir.
Thank you, sir.
Yes.
Now this is Dr. Amrita.
Uma Pandey.
No, you have mentioned Uma Pandey.
This is Dr. Uma Pandey. Yes. Dr. Uma Pandey, ma'am. No, but the question would be of Dr. Amrita first, I think.
Can I get the questions?
Yeah,
No,
Dr.
yes,
Uma.
if
Sir,
Uma
she
is
loves dancing, gardening, and she also makes herbariums, dried out flowers and all, to dry them and make herbariums.
Yeah, we used to do that. So the question is thank you, Asha ma'am, thank you, MC Patel sir. Question is a 26 years old, Gravida 3, Para 2, L2, having 22 weeks pregnancy for MTP with reason given failure of contraception. Can you do the MTP or not?
No,
Sir.
no. Here pregnancy has advanced 20 weeks and it is 22 weeks.
Yes, sir.
So indication of failure of contraception is available up to 20 weeks of pregnancy only. So we
Yes.
cannot terminate pregnancy.
Okay.
If it is more than 20 weeks.
So yeah. So that's the only question I have.
Any other question related to this you can ask.
Sir, can I have an extension to this question?
Yes.
Sir, if the woman says, she has a failure of contraception, but then she says that I am very mentally stressed out and it may cause me problems. And is there a way to report this case to the medical board and take permission?
That is available, but indication that is failure of contraception is not available in more than 20 weeks of pregnancy.
Okay.
If pregnancy is more than 20 weeks and less than 24 weeks, if any other indication which are given with this amendment of MTP Act, there are 7 indications given in this amendment. If any of indication is available, then we can terminate pregnancy. And if those 7 indications are not available and if pregnancy has advanced 24 weeks, then if there is a congenital fetal anomaly which are incompatible with life of fetus, then only medical board can opine. Otherwise, one may go to Honorable High Court seeking permission with writ petition. Otherwise, it is not available.
Thank you.
Thank you, sir.
Yes.
So, sir, this is Dr. Amrita. I've been asking so many gynecologists about their hobbies, but she does theater and she is so good. Other than theater, she does sports, cricket, basketball and all, but these are her theater photos. And it's really, I was awestruck. So over to you, Dr. Amrita. She's the
Thank
past
you,
president of Gorakhpur Society.
Yes, welcome, Amrita.
Thank you, sir. Good evening. And thanks to you, Dr. Asha Jain and Dr. Rajshekhar for giving me this opportunity. My regards to all the dignitaries, seniors, teachers, and guests of honor present here. My question is that if we have done MTP for more than 24 weeks for any reason, and the baby is live, so to whom custody should be given?
Naturally, yes, you can take all the question and I will answer all the questions.
Yes, sir. And the other, if the patients or the relatives are not willing to take the custody, then what? And the baby lives longer and needs ICU care, who will pay for the an ICU expenses? And should we inform the police for this? Or would it be considered as a feticide or something? Or whatever, sir. Over to you. I mean,
so
it's a confusing question. And
this is very tricky
confusing
situation. So our obstetrician friends are facing. So after this amendment, now termination of pregnancy is available beyond 24 weeks of pregnancy also. So at the time of taking consent, we should be very careful. At the time of taking consent, we should explain that there are possibility that fetus may come alive. And in this situation, you will have to take custody. So if patients and relatives are ready to take custody of baby, it's fine. But many a time, once pregnancy is terminated and baby is alive, relatives are not ready to take custody. And we cannot leave that very baby at mercy to die. So we are under obligation to shift that very baby in NICU. But in government setup, there is no problem. Baby can be shifted. But in private setup, who will pay bill of this NICU? So at the time of taking consent, we should take consent for that also. And if patient or patient party are not willing, then here comes role of police. We can inform police also that this situation has arisen and you take necessary action. This is last question. Can prior feticide be considered? This is one more gray area. As far as MTP part is concerned, it is not mentioned anywhere in MTP Act. So this is gray area. But to address all those questions before government, here comes role of IMA, role of FOXI. They should approach government with all these gray areas as far as this MTP Act is concerned and amendment of MTP Act is concerned to clarify the situation. So in a lighter way, many times I say, so if you will vote for me and if I am President FOXI, I am going to take all those questions before government to solve all this query. But it is in a lighter way, not to be
all
serious.
the best to you, sir, for your
Thank you.
elections.
Thank you, Amrita.
Thank you, sir. Thank you for your answers.
So this is Dr. Archana Mishra, sir. This is her painting of a swan, and she loves to do painting, also music, and she is the director of Alok Hospital, Varanasi. So over to you, Dr. Archana.
Namaste.
Namaste.
Namaste, everyone.
Namaste.
I'm honored to be a panelist in this prestigious panel. My sincere thanks to Dr. Patel, Dr. Asha, and Dr. Ritu Khanna. My question to Patel sir is that a 19 years unmarried girl was brought to hospital in shock by an A&M practicing in periphery who did her criminal abortion at her clinic at 3 months of pregnancy. And the patient was accompanied with her parents. On examination, the patient was in shock. Omentum was hanging through the vagina. So my question is, what's to be done? And first, resuscitation and management, or should we do a PIR and wait for police to come? Sir,
So,
please.
before I
Sorry,
answer,
that's a printing mistake. It's FIR.
FIR, yes.
Yeah.
So before I answer, we had a very nice time with Dr. Archana Mishra madam during
Yes, sir.
FIGO conference and extended tour for 11
Yes,
days.
sir.
So I do remember and cherish sweet memory with you, madam. So
Yes, sir.
in this type of situation, it is a case of criminal abortion. If patient and patient party are willing to inform police, naturally we will have to inform police. But first we will have to treat patient. Because in one of the famous case of Parmanand Katara, court has very specifically mentioned, first you treat the patient, all the legal formalities afterwards. And when patient is in shock and patient is in a serious condition, naturally we have to resuscitate patient, we have to manage patient accordingly, and then after we have to inform police if at all patient and patient party are interested to file case against that very A&M who had done this criminal abortion. So we should be very clear in this type of situation. And once we inform police, we are not complainant. We are only informer. Complainant will be either patient or relative of the patient. So it should be very clear at the time of informing police also. This is to inform you that way we have to inform that this type of patient was brought to me in condition of shock. I am treating this patient and I am informing to you to do needful. That's all. So whether police turns up, whether police doesn't turn, we are not under obligation. Once we inform, our job is over. But there should be willingness on part of patient, because many a time when patient is major, patient can take decision whether to lodge complaints against that very A&M or not. If patient is not willing to lodge complaint, then we have not to inform police. And if patient is comfortable, if relative are comfortable, then they may complain or lodge complaint before police.
Thank you very much, sir.
Yes.
Thank you, sir. Thank you,
Yes.
Dr. Archana. And this is Dr. Babita, sir. So she loves dancing and she says she compares everything and she dances all the time. So these are various images of her. And she is the Vice President, Gorakhpur Obstetric Gynec Society. Over to you, Dr. Babita.
Thank you, ma'am. Thank you, sir, for involving me in such a lovely panel discussion. So my question is, a patient comes to a 22-year-old girl. She comes to you with a boyfriend with 23 weeks pregnancy, 3.5 months pregnancy. What next to be done? She wants termination to be done.
Yes. So even if she is unmarried, but she is major, and when she is major, she can give valid consent for termination of pregnancy. If center is registered, if person is qualified, pregnancy can be terminated. But in this type of situation, we should be very careful, because many times it happens, and it very recently happened in state of Gujarat only. In this type of situation, pregnancy was terminated. After 6 months, police came and asked the doctor that very patient, her pregnancy was terminated here in your hospital. Now patient has lodged a complaint against that very boyfriend, that I had given consent to that boyfriend with against promise of marriage, and now he has declined to get married. So it becomes a case of rape. So police came to that very doctor, and police told that when it is a case of rape, why you didn't inform police? So in this type of situation, when patient is major and patient is unmarried, of course you can terminate pregnancy. No law can prevent you, because if your center is registered, you are a qualified person, you can terminate pregnancy. But to be on safer side, and not to end up into this type of problem, we should take in writing of our patient's own handwriting, or we can write and patient can sign that it is a result of consensual sex. I have no complaint against anybody, and I do not want to inform police. Because at that very point of time, patient is very clear. She has no complaints against anybody, including her boyfriend. She is not willing to complain or inform police. And if she gives this type of writing, or she gives consent like that, then you are out of problem. And in recent past, in one of the case, Supreme Court had an observation. If any lady is living with her boyfriend for 5 years or more than that, or she is willing and she is in active sexual life with her boyfriend, and suddenly there is some dispute, how it can be considered as a case of rape when she was willing for 5 years? So in this type of situation, we are safe, nothing to worry, but this type of writing should be there in our consent. So we will be safe.
So one more thing, the onus, like she is saying 22-year-old. So should we keep a age proof for such patients?
Yes, naturally. If we are confident enough that she is major, more than 18 weeks, fine. But even if at all we are in a dilemma about her age, we can ask for any ID proof. School leaving certificate, election card, driving license, Aadhaar card, any document you can ask for. And one more advice, to be very much precise, whenever we ask for any copy of Aadhaar card or any ID proof, that very copy should be attested by patient herself. Because many a time what happens, it could be fake one. Because in one of the cases, it happened in state of Tamil Nadu only. Aadhaar card was produced, but it was fake one, and doctor was put into trouble. So it should be attested by patient. So even if it is fake, then there will be one more case with patient that what it is in eye of law, it is called there is specific word I will mention. So misappropriation of evidence also, it is called like this. So there should be attestation on part of patient.
Thank you, sir.
So here, sir, we have Dr. Upma Yadav Jaiswal. You know, she's one person who said that she is basically in a everyday competition with herself to improve herself and find beauty in everything, and gardening. So you can see her garden here, sir. And she is the director, Swastik Marigold Hospital, Gorakhpur. Over to you, Dr. Upma.
Thank you, sir. And thank you, ma'am, for making me part of this national series of masterclass series of sir. Sir, I would like to ask you, a 29-year-old patient came to me who has conceived with ART, and she has now conceived with triplets as seen on ultrasound, and was advised fetal reduction. And generally it is advised after 12 weeks only when the first NT&B scan is done. And I would like to ask, should that center be registered for MTP or does it come under the preview of MTP Act? And which forms are to be filled for this procedure?
So in this type of cases of fetal reduction, even after fetal reduction, pregnancy is continued. So it is not termination of pregnancy. It doesn't come in purview of MTP Act. So no need to go for any kind of form. And in this situation, even center need not to be registered. Even if at unregistered place, fetal reduction can also be undertaken.
Thank you so much, sir.
Thank you, sir.
Yes.
And now we have our Dr. Bharti. So she loves acting, dancing and traveling and gardening and whatnot. And she is going for perinatology committee right this year. So she's also the president-elect of Kasoga. Over to you, Dr. Bharti.
Thank you, Dr. Asha. Sir, a teenager girl, a girl comes, I can't see this slide. Just a minute. Let me minimize this. I'm not able to read the slide. Sorry. Yeah. So the center is registered, sir. There's a girl who comes for a 6 weeks pregnancy. She wants an MTP, but she has come unattended. So will you do a medical method of MTP because she has come alone? And if she wants a surgical abortion, then what would we do?
So if she is major and if she has come alone, as far as medical method of termination of pregnancy is concerned, nothing to worry. You can very well prescribe her medical method with all this informed consent and Form C, Form 1, etc. But if it is surgical one, then we should be very careful, because in one of the cases which happened in city of Pune only, patient was major, center was registered, person was qualified, and patient was for surgical termination by surgical method. And she was alone, and unlucky on part of patient as well as that doctor also, it went with perforation and there was profuse bleeding, blood transfusion was required, laparotomy was required. And in this situation, doctor informed patient's relative. Patient relative came, case was well managed, patient was saved. But relative were very angry to the doctor, why you didn't inform before termination of pregnancy. So whenever you are going to go for surgical abortion, at least some responsible person should be with patient outside operation theater. So it is very much required.
Sir, another extension in this, is the ultrasound before the medical method of MTP mandatory?
So as per law, it is not mandatory, because nowhere in MTP Act it is written that ultrasound examination is compulsory before termination of pregnancy. But to be on safer side, to rule out ectopic pregnancy, say for example, tubal, ovarian, abdominal, cervical, rudimentary horn. So if we have ruled out, then it will be in our favor, because if at all something goes wrong, say for example, if it is ectopic one and it is missed and somebody has gone with curettage in normal uterus, because it happened in one of the case, it was rudimentary horn pregnancy, and one of our Foxian friend went with termination of pregnancy like DNE in normal uterus. Pregnancy was continued, and ultimately it was rupture of rudimentary horn. Patient was serious, and of course patient was saved, but case was filed against doctor. So not to end up into this type of situation, though it is not mandatory under MTP Act, but it is always advisable to go for ultrasound examination to rule out, of course, if you are sure of by your clinical acumen that it is a pakka intrauterine pregnancy, and if you have not advised ultrasound examination, fine, you cannot be challenged for that ground. But if at all something goes wrong, for any complication, patient may sue you. If you are legally sound as far as MTP Act provisions are concerned, but as far as any complications are concerned, in any other case, if complications happens and if patient can lodge complaint against you, then patient can lodge complaints against you in complication related to MTP services also. So if you have taken into consideration to go for ultrasound examination, it shows your consent to take care of patient. It is always better, not mandatory, but advisable.
Thank you, sir.
So any
Yes.
other question by
Yes,
any
yes.
panelist? Yes, Dr.
Upma Jaiswal madam has raised question.
Has a question.
Yes.
Sir, I just want to know when ectopic pregnancy which comes to us, if we medically manage it, or we have to, sometimes we encounter ruptured ectopic or even scar pregnancy. What is the role of MTP form in it? Which form to be
No, no,
formed?
it is complication of pregnancy, madam. It doesn't come in purview of MTPX, so no need to go for any form. No form C, no form 1, nothing. You have to simply manage that case as we manage any other case.
So not even for medical management, also for ectopic, we don't.
It is complication.
Okay, sir.
Because the same question was raised in 2012 in one of RTI. And in that very RTI, it was very clear. Incomplete abortion, blighted ovum, ectopic pregnancy, some any other complication was also mentioned in that RTI. And in that very RTI, it was very clear on part of central government that these are the complications of pregnancy and you will have to manage that very case as per standard medical norms. It doesn't come in purview of MTP Act, so no need to go for any formality related to MTP Act.
So if a girl is less than 18 years of age and she comes with pregnancy, then to inform the police in it?
Yes, it is mandatory. Because if she is less than 18, it becomes a case of POXO. So, even if she is not willing to get her pregnancy terminated, then also you are under obligation to inform police. Because once you came to know that she is less than 18 and she is pregnant, it becomes a case of POXO. And under section 19 of POXO Act, you have to inform police.
So
Police or CWC.
So any patient who comes to us in OPD with teenage pregnancy, we have to inform the police.
Yes, naturally. Once you come to know, because in that very POXO Act, it is very specifically written, notwithstanding any condition, whenever any responsible citizen of India, word responsible citizen of India is used, comes to know that she is victim of sexual offense, or she is likely to be victim of sexual offense, you have to inform police or CWC, that is Child Welfare Committee. So
May I ask one question?
May I ask?
May I ask one question, Dr. Patel?
Yes.
I just now you have said that medical abortion can be given if the girl is above 18. Suppose there is a girl from the hostel, she comes to us, she's more than 18. And after investigations, we give her medical abortion. In the hostel, now she is bleeding, and now she comes into shock. The parents are informed. Maybe the warden brings the patient to the hospital. She's being taken care of. But the confidentiality is lost. The parents would go against the doctor for a SOE. What is the situation then?
So
it is not that medical abortion is not having any complication.
No. Even if when she is more than 18, when she is mentally sound, she can give consent for termination of pregnancy.
Yes.
So for that part, you are not challenged legally.
Yes.
As far as complication part is concerned, she is ended into bleeding. If it is incomplete abortion or any other reason for infection or any other reason. So one can sue any doctor for complication. It is done in any other case, say for complication of cesarean section, complication of your normal delivery. So same way one can be sued in court of law. Otherwise, not to inform parents cannot be the ground for litigation. It is very clear. But for complication, one can.
Okay, but should not we ask the girl to have some or other responsible person so that if any complication is there, she can come along with him?
If you are going to terminate pregnancy by medical method, then no need. We will take informed consent with all mentioning that there is a possibility of incomplete abortion, retained product, persistent bleeding, possibility of infection. So we mention everything in informed consent. And just I mentioned it is available on Foxy website. We 3 people, including myself, we have prepared consent. In that very consent, we have very specifically mentioned everything, because we have prepared those consent taking base of famous case of Samira Kohli versus Prabha Manchanda, which was decided in 2008 in Supreme Court. In that very case, Supreme Court came out with a very detailed discussion what should be the ideal consent in Indian consent. And we have made those consent in 2 parts. Part 1 is information and part 2 is undertaking. So in part 1, there are some 8 subheadings. And in all those subheading name, that is termination of pregnancy by medical method. Meanings, what is the meaning of termination of pregnancy by medical method? What is the indication? How it will work, this medical method. Probable complications, consequences of refusal. So in all those form, we have mentioned everything. And part 2 is undertaking. So once patient goes with undertaking and signs the document, that it is presumed by law that she has read all this and she was well versed with the probable complication. So if it is with medical method, it's fine. But if we are going with surgical method, just I mentioned prior also, some responsible person should be waiting outside the operation theatre. Because if at all it ends up into any serious consequences, then the one person should be there to take care.
Thank you.
Yes. Yes, Upma, madam.
May I take
So
one
if
question?
if a patient comes to us of less than 18 years of age, she comes with a friend and she says like, I want termination of the pregnancy. It was consensual, not rape or anything. We have to inform the police, and then can we give her abortion pills?
Oh yes. Once we have informed police, if our center is registered, we are qualified person, with consent of any guardian, we can terminate pregnancy. Even her boyfriend can also.
Without her parents, she has come only with
Yes, without.
boy.
Here word guardian is used, and word guardian means person who guards the patient. Even her boyfriend, if he is major, because to give consent, one should be major, even relative. So if boyfriend is major, more than 21 years, and if he is mentally sound, he can also give consent to terminate pregnancy. But when she is less than 18, it becomes a case of POXO. So we will have to inform police. We will have to preserve product of conception in normal saline, and we will have to hand over that product of conception to the police.
Yes.
Thank you, sir. Thank you.
Sir, I've got a
Dr. Savita
question.
wanted to say something.
Yeah. For how long we can keep the consent form, consent form, for how long we have to
So
keep?
as far as any record related to MTP services, we have to preserve record for 5 years.
For 5 years. One
And
more question.
if there is any litigation, then till the final decision of litigation, or 5 years, whichever is later.
Okay, thank you, sir. One more question. Now the cesareans are increasing, so the patients are coming with early pregnancy with 1 or more cesarean section. If we take the informed consent and explain the complication of cesarean, perforation, hemorrhage, and remote complication like infertility, then they say, we have come for the expert opinion and for expert treatment. आप हमें डरा रही हैं. So sometimes it happens. So what to do in such cases?
It may happen, but we have to go with informed consent. With all possible probable complication, we have to explain. And not only we have to explain, but we have to mention in consent form also. So if you go with our consent, which we have prepared and available on Foxy website, everything we have given in detail. Say for example, cesarean section. If you go with that very consent which we have prepared, you will appreciate that we have taken each and every point into consideration at the time of taking consent for cesarean section also.
One more question. If the fetus is lethal after 24 weeks of pregnancy, then the woman has to appear in front of the board. Then where the confidentiality is there?
Still, we have not terminated pregnancy. She is for termination of pregnancy. She is seeking our termination of pregnancy. And when medical board gives opinion that pregnancy can be terminated, still pregnancy is not terminated. When we consider to terminate that very pregnancy with all the provisions of MTP Act, then we will enter all the details in Form 3. And then that very point of time, confidentiality starts. Before that, we have not terminated pregnancy.
She has been exposed to everybody, to so
Pardon?
many persons that she will go for the termination.
No, not necessary. She has taken opinion. She may decline after opinion also. It is not necessary. In eye of law, it is very clear. Till you have not terminated pregnancy, and till you have not entered our information in Form 3, you have not breached any confidentiality of any patient.
Okay. Thank you, sir. Thank you.
Thank you, sir. So, sir, we have Dr. Vibha is still with us.
Yes, you mentioned otherwise. I was to request Dr. Vibha madam.
So if she wants
for
to
her
make a
expert comments.
any comment, Dr. Vibha, any comment from you, please?
Vibha madam.
She hasn't logged out, but I don't think she's.
Yes, she is there. And before she takes over, my humble appeal again to endorse my candidature for post of President Foxy election year 2024. In month of May, there will be request from Foxy to each and every society for nomination. So first society will nominate me, and in month of August, all the members who are voters will vote for me. And same way for Asha and for Dr. Bharti. Because Asha is going for Food, Drug and Medical Surgical Equipment Committee. Now the same committee is held by Dr. Ritu Khanna, and from Ritu Khanna, let us hope it should be taken by Dr. Asha Jain. But it can only be possible by support of all of you. And same way for Bharti, for Perinatology Committee.
Thank you, sir.
Thank you so much. Thank you, everyone, for actually being here and spending your precious time with all of us. And yes, Dr. Bharti, you can also make your appeal.
No.
I've already made it for you.
Yeah, namaste. And I thank Dr. MC Patel for always being with us. Thank all our esteemed senior faculty members, Dr. Reena Srivastav, Dr. Savita, Dr. Vibha ma'am. We seek your blessings and support for the Foxy Perinatal Neonatology Committee. Kindly nominate me and support me. Namaste. And the same.
May you all come out with flying colors. Dr.
Thank
Patel,
you, madam.
Dr.
Thank you.
Asha, Dr. Bharti.
Thank you. Thank you, ma'am.
Thank you. Thank you, madam.
Thank you, ma'am.
So we take opportunity to thank all the participants, all the faculties, guests, panelists, and of course, Corona Remedy are with us in this series since long, and particularly Dr. Nilesh and Tirth. They are very kind, because whenever we send any flyer for correction or so, they will be immediately responding our call. So thank you, Nilesh, for the same.
Thank you
you,
so
sir.
much, sir. Thank you, sir.
So thank you, MC Patel, sir. Thank you, our chief guest of honors, chairpersons, panelists, conveners, everyone. Thank you for not getting irritated with my call and responding so beautifully. Thank you once again.
So
Hope to see you again.
as Dr. Asha,
Yes, sir.
today my situation was like just I was going for we were going in exam of MD. So one poor student and all these examiners. So my question to examiner now, am I passed?
Distinction, sir. Gold medal.
Excellent performance.
Sir, we missed you. You were supposed to be with us in Hassan yesterday.
Oh, yes.
According to the previous plan.
Very hectic schedule.
I know, sir.
Just in beginning, Dr. Asha mentioned about my services in Northeast.
Yes.
Actually, these services we do in month of March, but this time due to incoming election in 24, they have kept in month of December only. So from 3rd to 10th, I'll be there in Northeast for medical camp, and this is my 21st year, Asha.
Okay.
So since 20 years we are going there, and this is our 21st year. So at a time, there will be team of 2 doctors and 3 medical student, third year student and above, intern, resident. And at a time in all the state of Northeast, all the 7 states, we will be working. So all the teams will be working in all the state. And almost near 100 teams are working. And one good part, each and every participant comes there on their own expense, from their own.
But it would be really cold now over there.
Yes, yes.
Yeah, now
It
right
will be
now.
cold.
Because cold and rain, even clothes don't dry. It will be tough.
In month of February, when I was posted in Meghalaya, when I went to our first center where we had to go for camp next day, it was -1 temperature.
God.
But we live in their houses only, because we go in very remote places, small huts. They give us one room with good blankets, good woolen blankets. So even if it is -1, then we were comfortable in the room. And we eat their usual food. And rice and dal is very much common in those areas. And you won't believe, total rice I eat in a month, I eat in 1 day only. So, because only rice is available. But we are comfortable that way also, because we are mentally prepared to be with them, to be with like them. So we observe their family life, how they live, how they work, and we have very good conversation, because at night we are free. After camp, we are free and we are with their family. So all the family members and our team, we sit together and we have a good conversation with them also.
Nice.
There is an exchange of ideas, exchange of knowledge. It is a very important thing. And you.
That's great.
I will
That's
take
great,
one more
Dr. Patel.
minute. In long back, when I was in Arunachal Pradesh, in one very small village and in one very small hut, we were for lunch, and they served with me a papad. I was surprised how with rice and dal, how this papad came. So I asked them. So they told me that when there is a very VIP guest, we offer papad. So otherwise, I never thought of papad. It could be there in Arunachal Pradesh in very remote area. Because once we leave Guwahati, up to Guwahati, roti, puri, everything is available. But once we leave Guwahati and we go in remote places in any state, Tripura, Mizoram, Nagaland, Arunachal, anywhere, no any roti, parotha, puri is available. Only rice and only rice. And rice they cultivate in their field only, and they call it dhan. So it is dhan actually. We call it rice.
So dhan is the precursor of rice, no?
Yes.
Okay. Dhan se hi to rice
very
banega.
tasty. I would say it is very tasty. We enjoy. And that very dhan and dal we enjoy. But they serve some vegetables also, because nearby their house they cultivate some vegetables also. And from that vegetable, they prepare vegetable. They prepare good bhaji also, which is available, any bhaji available in nearby. They will bring it and they will prepare bhaji. So in few of the huts, we are served with rice, dal, vegetables and bhaji.
Bhaji.
Sir, should we end the session now?
Oh yes. Oh yes.
So
Thank you.
everyone.
Thank you, Dr. Patel.
Namaskar.
Thank you, everybody.
Thank you. I'm ending the session now.
Oh yes. Oh yes.
Thank
Bye,
you so much
everybody.
for your time. Thank you so much. Thank you.